Hello, I just want to talk today about vertebral compression fractures, which is just a fracture in the back which happens through compression. So normally kind of axial loading of pressure sort of coming down. Very common more in the elderly and in patients with OA, but elderly more like a well-worn spine rather than specifically in sort of the frail elderly, although obviously more common in the frail elderly. I hate to use those terms, sounds a bit sort of age phobic. But just this is stimulated by a patient I had in earlier this week who came in complaining of pain in his kidneys. He passed out through low blood sugar, he's a diabetic, and had sort of fallen in the bathroom, hit his head, but he didn't remember the fall itself. And he had a history of back pain, and after the fall, his pain had been much worse. And I'd been to his doctors, and he was convinced he had a sort of problem back in his kidneys. And his GP, who's excellent, looked him over and suggested he needed physio and didn't do any further imaging. And when he came in to see me, he was still sort of complaining of the pain in the kidney region, and no other real symptoms, nothing sort of referred into the legs, no other obvious red flags. And then interestingly, on assessment, sort of on forward flexion, he was completely pain-free. He's stiff, but pain-free. And then on extension, he had pain. Side flexion was pain-free, both sides. The only movements sort of on assessment that were actually painful was abduction of the right leg and adduction of the left leg. And to be honest, I'm not 100% sure on the mechanism of this. It must be that the fracture is moving in such a way that these movements are irritating it. But at the moment, I don't fully understand the mechanics of why those particular movements were irritating it. And then on palpation, he had like very classic point tenderness over both T12, L1 and L2, and particularly on the right side. And given the pattern of the fall, no imaging, and how he was definitely exquisitely tender to palpation, I suggested an MRI, and the findings came back with he had an L1 compression fracture. So it's actually not that bad a condition. It sounds quite bad to have a broken back or a fracture in your spine, but it's actually not too bad, and these do heal. So particularly if you're younger, you can maybe be looking at more towards 4 weeks, and younger is more of a just how your body is younger rather than a specific age thing. You know, if you're eating well, you've got good bone density, which it's unlikely you get this problem if you do have good bone density. But you can potentially recover quite quickly. And if you're more towards the other end of the spectrum, perhaps you're sort of in your 80s, your general health could be a bit better, then you could be looking at more towards kind of almost 3 months. And often quite typical present sort of response to this is it's about 3 months before a patient is pain-free. So if you do get one of these, you need to get a brace is often a really good initial step, and just quite a loose supporting brace. The evidence is suggesting it doesn't have to be anything too fixed. You can exercise, but you really want to keep the spine in neutral. Certainly you don't want to do any movements which create pain or irritate it. You want to keep that area relatively stable for the time being. A lot of our kind of older, more traditional physiotherapy exercises are more useful, sort of training more in a neutral spine, working on your classic trunk stabilizers. In particular, some of the evidence is suggesting that trunk extension exercises, working more on the lumbar paraspinals, appears to help actually reduce pain in these patients. I think you really have to take this on a case-by-case basis and understand the mechanics of someone's back, how the compression fracture fits in with their existing presentation in terms of their existing positives and negatives in terms of how they move. And the other thing, obviously, is to look at the diet and lifestyle. So these patients If you're getting a compression fracture, the chances are your diet and lifestyle could be better, and the bone density isn't fantastic. A DEXA scan is pretty essential, and you want to be looking at vitamin D levels, calcium to magnesium ratios, and ideally getting red blood cell level checked to understand that better. The Nutri-Eval by Genova Diagnostics is my favourite test for that. It's wildly expensive, but it does look at the full gamut of what's going on nutritionally, and you can really start to understand someone's metabolism by doing that. So that's a good way to actually really understand the underlying sort of physiology and biochemistry of what needs to be done, and then to put a really specific plan in place based around diet and also supplementation, which can often be really useful. At a more basic level, any good GP should, once a patient has these symptoms, they'll do a DEXA scan and vitamin D level testing, and they'll probably also consider, they'll do blood work, and even blood levels of calcium may well show as low in these patients. So calcium supplementation could be useful. From a nutritional therapy perspective, you always want to then look at calcium magnesium ratio, and if the patient won't do testing, then I would look at your kind of common magnesium symptoms, your muscle aches, your digestive complaints, and the full kind of get a full picture of what the magnesium sort of symptomatology, magnesium, the pattern of symptoms associated with potential magnesium deficiency, so you can potentially understand that. But ideally, you really do want to get blood work done. Obviously, if you are a primary care giver and you're in a position where a patient comes in from me, for example, with this one, you MRI them, which is within your remit to do, and you then find out they have something like this, they do need to see a consultant. Because there are times when these need to be operated on. Also injections, so like a corticosteroid injection, and correct pain management is really important in these patients, and so it might well be something well above what they're being, like what's available over the counter, that could be really useful in terms of managing their pain. So certainly a referral to a pain consultant. That's obviously what I did in this case. It's been interesting though discussing these compression fractures with other colleagues, both online and offline, and there's quite a few that can occur through people just stepping down. So if you're in an elderly patient, particularly with the osteoporotic elderly patient, just stepping down off a step and jarring the back can be enough to create one of these compression fractures, it seems. It's probably a straw that broke the camel's back situation. It's probably been nearly gone in a very unhealthy segment. But prior to that, for as little as stepping down a step and just a little jar creating the symptoms. But it's definitely something to bear in mind with regard to the presentation. So really quite minor mechanical insults in the right type of patient should make us think about a compression fracture and the potential need for imaging. But hopefully that's of some use to you if you're interested in vertebral compression fractures and just getting a quick understanding of some of the basics. It's nowhere near as bad as it sounds, and outcomes are generally really pretty good. Sort of the what we call red flags that we have to kind of and the pathologies associated with it, it's certainly one of the less serious that you could get. All the best. Bye.